So this is my case this week. This just happened in the past couple weeks that I came across this case. And it's one of the few times that I've actually seen this particular diagnosis in the wild. So CT of this patient, obviously pretty severe emphysema, mostly in the upper lobes. As we come down, we can see it's a little bit less severe, lower down in the lungs. And so at our institution, occasionally patients who have, poor oxygenation status, who have really severe emphysema, may get treated with endobronchial valves, which is what happened with this patient. So here on this first chest radiograph, we can see three of these little metallic structures that are projecting over the right hilum. And these are placed endobronchially, in this case, within the right upper lobe. And what's happened here is that that right upper lobe is now almost completely collapsed, which is what we expect from these endobronchial valves. You can see there's a little bit of aeration still at the distal aspect of that upper lobe. But as the day goes on, we can see that that gets less and less. Right, again, that lobe is collapsing, which again is the intended purpose of these valves. We collapse that really emphysematous lobe so that the less diseased lung has more space to fill the thorax and participate in gas exchange. However, as this patient was sitting in the hospital after this had happened, right, and again, here we see that nice complete collapse of that upper lobe. Uh, on this same day, the patient suddenly experienced sharp chest pain. And so they repeated a radiograph. And what's happened now is that there is a pneumothorax on that right side. So we can see that that collapsed right upper lobe has fallen away from the apex of the lung, and we can see this nice line of the pleura here. So this would be what I would call an ex vacuo pneumothorax. I think this is a sort of true manifestation of that particular um, diagnosis, where this pneumothorax is caused by that rapid collapse of an entire lobe of the lung, which exerts, increased negative pressure on the pleural space and causes air to rush into that space, right? It's not that we've punctured through the pleura to let air into that space. It's caused by that rapid lobar collapse. And I think that term clinically occasionally will get used incorrectly to refer to patients who, have a long-standing pleural effusion with a bunch of pleural thickening and like a rind that forms, and then we drain the pleural fluid, and that cavity still stays open. The lung doesn't re-expand. So that is a slightly different entity than this, which is caused by this really acute rapid collapse of the lobe. So it's just a nice case of that.
Excellent. You know, it's interesting. How many days, I'm sorry, from when they put the valves into when they got the ex
This
vacuum?
was this was this day two. So they put it
Okay.
in one day, and then the patient was sort of staying overnight to monitor, and then on the day after the valve was put in, this happened.
Yeah, it seems to happen not uncommonly. I know we do a lot of valves
Hmm.
here now, and I've seen quite a few pneumothoraces. Um, but if it's truly ex vacuo, then do you just, so what, did they just watch it or did
I
they, I
mean,
mean,
they watched it for a while. It continued to get bigger, and so eventually they had IR put a pigtail catheter in to try and, I don't know,
mhm.
get rid of some of that air. It hasn't really worked.
Yeah,
He's
because
been sort of
it,
unfortunately sitting here with this for a while, so I
right,
think they're
because the
debating
upper lobe,
whether to, yeah,
yeah, because it can't re-expand.
exactly. So they're thinking about whether they need to go back in and sort of take at least one or two of the valves out to see if
Yeah,
they can re-expand that lung a
and
little
the
bit.
other nice thing about that case too is like we've shown in the past, I think, and Howard showed the article, it's like the pneumothorax is confined to that lobe too, like that
Hmm.
space.
Yes.
Yeah,
Yeah,
so
I
really
actually think
cool.
we have a repeat CT after because they, I don't know, wanted to get a repeat CT, and you can see just how big that pneumo is, and that complete collapse really nicely of that upper lobe, but the rest of the lobes are just their normal size. But yeah,
Very
anyways,
nice.
that's my
All right, well,
case.
thanks.
Thank
All
you.
right, I've got three I can show. Okay, so This is a patient with Sjogren's syndrome, and this has two different diagnoses, both related. Um, and so on this scan here, there we go. If we look, we can see already at the top, we have some subpleural reticulation, some traction bronchiectasis, and then we that are centimeter plus, some stuff around the airways here in the right lower lobe, and then this reticulation goes all the way down to the bottom here. So we have pulmonary fibrosis, so of course you can see that with Sjogren's syndrome. They can get UIP, NSIP, some unclassifiable one. But when we see nodules, the other thing we have to think about are a couple things. Well, actually, a couple things we have to think about are lymphomas, but you also have to think about amyloid deposition. Howard's talked about that and shown some cases. And so you can see there's a larger nodule here. So this got biopsied, and this is an amyloidoma here. Interesting, there's not cystic disease in this patient that we often see mixed with the so-called radiologic LIP, which, if you haven't, there's a recent journal, I think it was in a PATH journal, Travis shared it with me back in January, where they looked at LIP on biopsies and on, I forgot how many, it was multi-center, they had to get enough cases, and the bottom line was what the pathologists call LIP and what we call LIP are not the same things. But what we call LIP is highly associated with Sjogren's syndrome and risk for B-cell malignancy. So there is a reason, I mean, it's worth biopsying these to prove this isn't lymphoma. But this is amyloidosis plus pulmonary fibrosis related to Sjogren's syndrome. So kind of neat because it doesn't have the cystic disease. I don't know if Maya or Travis, if you've ever come across a case of multiple amyloidomas in the absence of cysts.
No, I don't think so.
I'll do this one last.
Yeah, great.
This is a neat case. So this patient presented with some chest pain, and you can see on the radiograph the left hemithorax is abnormal. There's some sort of ill-defined mass here. There's some ribs missing, some fractures or something there. So this was concerning for a mass or some trauma with a big hematoma. So it was an outpatient, so it wasn't an acute trauma. So they did a CT scan, and it shows lymphadenopathy in the left axilla. And then you see this soft tissue kind of all along the chest wall here, these multiple lytic lesions and pathologic fractures getting into the extrapleural space. There's also there's some pleural effusion here. So this sort of infiltrative chest wall mass. And so this was biopsied, and just before I knew what it was, we were trying to discuss different things this could be. I mean, it doesn't look like a lung primary. Could be melanomas, one I've seen with chest wall mets, axillary nodes. It's a male patient. There's no findings of male breast carcinoma. Mets from somewhere else, but in this distribution, it's a little funny for that because there's no known malignancy. So they biopsied these soft tissue nodules, and this all came back as diffuse large B-cell lymphoma, which is not my first choice diagnosis, but it can be more destructive in the bones. I would have gone with melanoma given the extent of axillary nodes here, but all localized to that left hemithorax. So I suspect with treatment we'll see these bone lesions heal and these soft tissue masses get smaller. So an unusual manifestation of lymphoma, but can do all sorts of weird things. And then this last case is kind of a crazy one. I wish I had a radiograph, but this is a young person with these just extremely large neck masses, all these large vessels here. And you can see there's narrowing of the airway. And so this alone here just looks like a really big thyroid goiter. But what should be bothersome are all these other soft tissue nodules up here. And then if we go down, there's lung nodules here, and then there's a lytic lesion somewhere down. Yeah, there's a bone lesion right here, down here. So very hypervascular. So we think renal cell, thyroid, maybe some sarcomas is our typical ones. But this is just a giant thyroid goiter that unfortunately developed a thyroid carcinoma that then metastasized into the neck nodes and into the lungs and chest wall. But I think it's the largest goiter I've ever seen and one of the worst thyroid cancers. And it's a papillary. It's not an anaplastic. Um, and it's just recruited all of these vessels. So there was probably some component of neglect in here and that just, denial. And there may have been some social issues as far as getting access to care. But yeah, just an unusual manifestation of a thyroid cancer. And that is all I have this week.
Um, this is and this one I at least suggested a diagnosis. So this is a patient, maybe that's too noisy, that presented with shortness of breath, clearly going to have an abnormal radiograph, and comes in with just extensive nodularity. Some of it's kind of calcified, definitely some areas that are, calcified, a lot is not. Strikingly, peribronchovagal, or some of it at least, along the perilymphatic interstitium. No history of anything in terms of exposures. I have seen a couple cases of kind of exuberant dendriform ossification without a predisposing factor, no aspiration and no ILD or fibrosis. Doesn't look like, alveolar microthiasis or anything like that. I'm just curious if you guys, I feel like I've seen this before. I just don't remember what it is. I'm curious if you guys have any thoughts.
Well, you can always go with sarcoid.
Yeah, we threw that out there potentially. There's no lymphadenopathy. There's some
Yeah,
notes.
but
There's some notes, but
just
but
they're perilymphatic and if with no exposures. It looks like there might be some small airways disease too. I see some.
yeah, there is. So on the expiratory thin slices, so an it's hard to tell because it's
Right,
so many nodules,
but it's
but
a little
there
heterogeneous.
was,
Yeah, there's
it
probably some.
is, there is. Um, so yeah, we put in sarcoid in the differential, but we're really kind of stumped beyond
And then,
that.
I've seen a disseminated lung adeno do this.
Yeah, with the calcifications too.
Nah, that would be less like. I can't gauge. I'm trying to figure out how many are. It seems like a lot. Okay, maybe a lot of them are
N-
calcified.
Yeah, the
Yeah, like,
calcification's a good point.
yeah, some of them are calcified. Not all of them are, but
Yeah, I like
some of them are
sarcoid. That
very,
would be my first choice.
yeah. So hopefully she's going to go undergo a biopsy. Right now, they're kind of moved it because there was PHI for some reason on this thing. So sorry. Okay, so this is a young guy who comes in and has, you can see lungs are quite abnormal, pronounced mosaicism. These areas of what looks like kind of venous looking, I don't know, you can wonder if it's venous infarct or hemorrhage or something down there. Now, if you look, there's no PE. There is some confluent perihilar soft tissue, some adenopathy, borderline adenopathy, and then these areas of occlusion, which actually correspond to veins. So this is a vein that is occluded. And there are a couple of these areas around of some kind of venous occlusions. Another one right here. So macroscopic venous occlusion. And underwent a biopsy. Again, you could see this stuff that kind of looks venous infarcty, hemorrhage, and underwent a biopsy at NYU, excellent institution with good pathologists, who read it out, which I would kind of thinking was on that, and he has pulmonary hypertension, although not horrendous. They read it out as PVOD, PCH, and additionally there were some granulomas, but they didn't, because initially I have seen cases of sarcoid venulitis lead to macroscopic venous occlusions. PVOD to have central veins occluded like this. Now, what's fascinating is they put them on anticoagulation. Oh no, this is the wrong crap. I downloaded the virtual or the high KEV images, but some of these veins on follow-up studies did open back up, which itself is kind of weird. Here, not as much, but we do have some from here. I said I was kind of downloading this the last time. Oh, look at that. That's weird. So I don't know. This had resolved. This wasn't on present follow-up studies. That's really odd. This was, anyways, I was thinking some form of sarcoid venulitis or some granulomatous process. I don't know if you guys have any other thoughts, if you've seen, because it was reviewed here by our pathologists, and they really, even though they saw these areas of that looked like PCH PVOD, they said it looked more secondary. They weren't really sure as the cause, and we're kind of stumped on this one as well. Have you guys seen like macroscopic multiple veins being occluded by something?
No, other than sarcoid, and it was extrinsic compression, not in like your case, never.
Yeah, and we were wondering, could it be a vasculitis, that it has a preferential venous involvement, which again is unheard, kind of very strange.
Right.
I really,
Yeah, I showed one case of PVOD that was half proven that had what looked like macroscopic venous occlusion, but it may have just been super slow flow into the veins. And then
yeah,
we
and
had
that
one
was
case of like sarcoid PVOD where it was actually granulomas destroying the small veins.
so that's what I mean, because the
Yeah,
path I wanted the path like said they're scattered non-necrotizing granulomas, but none of the pathologists, either the one here or the one at NYU, suggested sarcoid. So I would think that they would do
yeah.
that. They're very good pathologists. I don't know, and I have seen one. I do have one case of PVOD by biopsy that had bigger veins occluded, but it's something that's very not typical. And he doesn't have like bad pulmonary hypertension.
And you said it improved on anticoagulation?
And it improved. Yeah, I wish I had that study. It got better on anticoagulation, the big clots. Um, I don't know. Just another weird case that even though we have path, we're still not 100% sure of the diagnosis. I'm going to try to get the path and maybe kind of send it to some vascular pathologists who may have a different idea. I'm not sure.
Very
But
interesting.
yeah, I have some other cases,
I've
but
never,
that's just
yeah, PVODs. I mean, it's because it's fibrosis of the air of the veins, so they don't get better.
right. No, that's the whole point. That's
Right.
exactly.
Yeah. And usually by
Um,
the time we see them, their pH is really bad.
right. And this guy presented with like pain because I think he was having venous infarcts.
Mm-hmm.
And right, again, I really wish I must have anonymized the wrong study, because on follow-up the veins are open. It's really weird.
Weird.
But yeah, so maybe I'll follow up on this at some point.
Okay.
Anyways, yeah.